All right, so we have primary angle closure glaucoma. They usually ask this, ask the questions about the treatment, management, and the clinical features, and the etiology of angle closure glaucoma or primary uh, angle closure glaucoma. So we'll just quickly go through it. Now there are two classifications mainly. There is an SGO classification, which is the International Society of Geographical and Epidemiological Ophthalmology. And there was a traditional clinical classification based on the duration of the symptoms seen. So, and some of them kind of correspond. So, according to the SGO classification, there are three categories of or classes. First one is primary angle closure suspect. Then there is primary angle closure, followed by primary angle closure glaucoma. Now, traditional clinical classification, which corresponds to each of these, is the latent primary angle closure glaucoma corresponds with primary angle closure glaucoma. Then subacute, acute, and chronic, they correspond with primary angle closure glaucoma. However, the chronic primary angle closure, which is traditionally, um, if it's asymptomatic, it corresponds with primary angle closure. But if it shows symptoms, then it corresponds with primary angle closure glaucoma, the final entity, which then leads to absolute glaucoma, where the IOP is extremely high and the angle is zero. Now coming to primary angle closure glaucoma, primary angle closure suspect. So this is not, the angle has not actually closed. And here, by the way, the angle we are talking about is the angle of the anterior chamber of the eye. Now, it hasn't completely closed. So, only when the patient comes to you for a routine checkup, there can be some suspicious clinical signs. Or if suppose there's an acute attack of a primary angle closure in one eye, then you can maybe check the other eye and then find out. Or during a routine screening program for glaucoma, you discover that the person is a suspect of primary angle closure or a latent primary angle closure glaucoma. So here there are no clinical features as such. The patient will not come with that. What the patient, but once you look for the signs that you may find, the suspicious clinical signs are these three. The first is the eclipse sign, which indicates that there is decreased axial anterior chamber, so chamber depth. So when you shine light across the anterior chamber from the temporal side, you will observe a shadow on the nasal side, and that is known as the eclipse sign. The second sign you will see is the slit lamp biomicroscopic sign, which again indicates decreased axial anterior chamber depth. It indicates convex shaped iris lens diaphragm and a close proximity of the iris to the cornea in the periphery. The third is you grade the angle according to the Van Herrick slit lamp grading. So what is this grading? I've written it here. Grade 4 is it's a completely widely open angle. Grade 3 is a mild narrow angle. So here what you're doing is you're comparing the peripheral anterior chamber depth to the adjacent corneal thickness. And if the peripheral anterior chamber depth is 3/4 to 1 times the corneal thickness, you grade it as a grade 4. And if it's 0, you grade it grade 0. So the thinner the anterior chamber depth gets as compared with the corneal thickness, the lesser your grade goes and the more severe the angle closure risk is. Now, coming back, how do you diagnose? There are various methods. The first one is intraocular pressure measurement, which should be normal, because if it's elevated, then you would definitely go to a primary angle closure, not a suspect. Secondly, gonioscopy, you will see that the contact between the iris and the trabeculae is more than 270 degrees, and the peripheral anterior synechiae are absent. So peripheral anterior synechiae or PAS is what they are the adhesions formed peripherally between the anterior chamber, like within the anterior chamber, basically, which kind of blocks the angle or narrows the angle. Then this UBM is ultrasonography. everything. Yeah, ultrasonic biomicroscopy. And anterior segment OCT. OCT was, I don't know what OCT is. Then you have optic disc evaluation, which will show no glaucomatous change, and visual field analysis again will be normal. So now, how do you manage it? Firstly, to precipitate a closure of the angle, you do a provocative test. So you are provoking the eye to actually close the angle and see if it's actually prone to angle closure. So the two tests are the prone darkroom test and the pharmacological the mydriatic test. So the prone darkroom test, you record the baseline intraocular pressure, and then the patient lies awake in a prone position in a dark room for about 1 hour, which will cause mydriasis automatically. And if there is an increase in the intraocular pressure of more than 8 millimeters by the end of this, I'm sorry, it should have been millimeters of mercury here, then it's diagnosed, it's a positive test. Similarly, a mydriatic provocative test is nothing but you cause a mid dilated pupil either by giving a mydriatic like tropicamide or a combination of both mydriatic and myotic. And when there is a mid dilated pupil, the risk of angle closure is the highest. So now if again there is an increase in IOP of more than 8 millimeters, because when the anterior chamber angle will reduce, the drainage of aqueous humor will reduce, causing an increase in the IOP. And if that is more than 8 millimeters, the inference is that the test is positive, which means that there can be a possibility of spontaneous closure of the angle, whereas you can rule it out if the test is negative. Now, how do you treat? You follow up periodically, and you may do a prophylactic laser iridotomy, because the risk of conversion to a primary angle closure glaucoma in the next 5 years is about 50%, which is quite high. Now, coming to the main and the more important part, which is primary angle closure. Uh, Now, how do you define primary angle closure? Is that the iridotrabecular contact on gonioscopy is more than 270 degrees. That means over 270 degrees, your iris and trabeculae, their pri primary peripheral anterior synechiae have formed, which cause an elevated IOP. However, the optic disc and visual fields are normal. So on optic disc is what you see, or like basically your fundoscopy, and your visual field is on perimetry. So both of them are normal and they're not affected. So you can't call it glaucoma, because the definition of glaucoma is the affection of optic disc and visual fields because of usually due to increased intraocular pressure. So now when there is a rise, when there's a transient rise of intraocular pressure, which may last only for about a couple of hours, you call it a subacute primary angle closure. And if so what happens is, in this you have recurrent attacks of unilateral transient blurring of vision associated with colored halos around light, headache, brow ache on the affected side. But these attacks, they terminate by themselves when you go to sleep or if you go in bright light. So, what are the precipitating factors for these attacks? They are physiological or pharmacological mydriasis, mydriasis will occur when you're in a dim light, etc., or you're watching television or cinema. Then there can be physiological shallowing of the anterior chamber, like we did after the provocative test. It's a physiological shallowing. So when all of this occurs, you have attacks, and in between the recurrent attacks, you are asymptomatic. So the signs that you see over here are all the same, that we just use for defining primary angle closure, which is your iridotrabecular contact is more than 270 degrees on as seen on gonioscopy. Your intraocular pressure is elevated, primary anterior synechia, peripheral anterior synechia are present. But all of this is seen in a white, non-congested eye. The eye is never congested. Now, if these attacks do not terminate on their own and they last for days, then you call it an acute primary angle closure and not a subacute one. And this usually occurs due to a pupillary block. So here what happens is the clinical features are a sudden onset of a very severe pain that radiates along the fifth cranial nerve, which is the trigeminal cranial nerve. You also see nausea, vomiting, prostrations, redness, photophobia, lacrimation. The signs seen are that The lids are edematous. Conjunctiva is chemosed and congested. Your anterior chamber is very shallow. I'm so sorry. Yes. Conjunctiva is chemosed and congested. Anterior chamber is very shallow with a Schaefer's grade of 0 on gonioscopy. The iris is discolored, intraocular pressure is markedly elevated with edematous optic disc, and the fellow eye may also have an occludable angle. So that now this fellow eye will show all of these suspicious clinical signs, and which is why you should do a peripheral laser iridotomy in the fellow eye as a prophylaxis. Now, how do you now the diagnosis is made on the clinical features, made based on the clinical features, and the differential diagnosis for an acute angle closure are the other causes of acute red eye along with the other acute secondary glaucomas. How you treat them is firstly you give them immediate medical therapy to lower the intraocular pressure. So you can give systemic hyperosmotic agents like mannitol, carbonic anhydrase inhibitors like acetazolamide, anti-glaucoma drugs, analgesics, antiemetics, topical steroids. The definitive treatment is a laser peripheral iridotomy. If that doesn't work, you can do a trabeculectomy, which is filtration surgery. Basically, you're allowing the filtration or the drainage of aqueous humor, or you can even do a clear lens extraction. Prophylaxis of the fellow eye, as we saw already, and in the long term, you monitor the eye basically, and both the eyes for precipitation of another such attack. Coming now to the primary angle closure glaucoma, which is the last final stage where all these are the same. Your iridotrabecular contact on gonioscopy is more than 270 degrees. Your eye intraocular pressure is elevated and the peripheral eye anterior synechiae are present. But the optic disc over here shows glaucomatous cupping and the visual field effects are seen, which are similar to those seen in primary open angle glaucoma. So here, this is a full-fledged actual glaucoma. Um, with with optic disc and visual field defects. So the pathogenesis over here is that it results from the gradual synechial closure of the angle of the anterior chamber, as we saw. Now, what are the clinical features? As we said, the everything is the same. Your signing on gonioscopy, you see contact of more than 270 degrees. There's an elevated IOP, peripheral anterior synechia present. It's a wide, painless eyeball with glaucomatous cupping of the optic disc and visual field defects, which are seen similar to primary open angle glaucoma. The treatment is you perform a laser iridotomy with medical therapy, trabeculectomy if required, and a prophylactic laser iridotomy in the fellow eye. What we missed doing is the sequelae of acute primary angle closure. So these are the sequelae. Your post-surgical acute primary angle closure may occur. If it's with a normal intraocular pressure, it's usually because of it usually shows warped striate. And if it's with a raised intraocular pressure, then it's because the treatment or the surgery has gone unsuccessful. So you can treat it with a trabeculectomy or a filtration surgery now. You can also have a spontaneous angle reopening, which is, although it's rare, and you treat it with a laser peripheral iridotomy. Now, because of all the necrosis and the surgery and the stress, the ciliary body may shut down and the aqueous humor production may stop. So this will lead to a lower intraocular pressure with a less pain in the eyeball. You treat it with topical steroids, a laser peripheral iridotomy. You monitor the intraocular pressure because it can rise suddenly. If it rises suddenly, then you do a trabeculectomy. Now, the warped striate is you see these three signs and symptoms. One is you see glaucom flecken, which is nothing but anterior subcapsular lenticular opacity. Is it 1 second? Yes, I'm right. Anterior subcapsular lenticular opacity, along with patches on iris atrophy and slightly dilated the patches of iris atrophy along with a slightly dilated non-reacting pupil. This is Voigt's trial. Now, what we studied or we discussed was that uh, you see colored halos uh, here in a primary subacute primary angle closure. So what are the differential diagnosis is when you see it in a primary angle closure, the patient usually says, I see colored halos or the colors of a rainbow while watching a bulb which is lighted or moon which is in dim light basically. If it's seen, colored halos are also seen in conjunctivitis, but when it these halos are eliminated when you irrigate the discharge, and if they're also seen in an immature cataract. So there you perform a Fincham's test. So what is a Fincham's test? Is that you pass a stenopaque slit across the pupil, and when you pass that slit across the pupil, the cataract is the halo which occurs because of cataract. It breaks up into segments, whereas it remains continuous like the rainbow in case if it's a glaucomatous halo. So that's how you differentiate between the colored halos of glaucoma, conjunctivitis, and cataract. So that was it about primary angle closure glaucoma. Uh, so I'll just quickly repeat that there are three steps or three classifications according to the SGO classification: primary angle closure suspect, primary angle closure, and primary angle closure glaucoma, which will ultimately lead to absolute glaucoma. Angle closure glaucoma with a Schaefer's grading of 0. That is, the angle is completely blocked. So, thank you.